The next case I want to present is a more radiological case, and it's a particular observation we had some time ago. It was a patient with no symptoms who had an incidental detection of a ductal lesion in the tail of the pancreas. And the lesion was demonstrated at CT and confirmed with this MR study. Well, this was a relatively asymptomatic patient, and we can consider these findings an incidental finding, or whether that patient moved to a PET-CT scan. And this PET-CT scan confirmed the presence of the supposed lesion in the tail of the pancreas with elevated SUV. I cannot show you the level of SUV, but as you can see, it was a positive finding at gallium PET. This is not a recent case, but on the basis of these imaging findings, the patient was operated, and the diagnosis, the preoperative diagnosis was not correct by us because in reality was not performed completely at our hospital, but it was supposed to be a neuroendocrine tumor in the tail of the pancreas. Well, the diagnosis was an intrapancreatic spleen. And you may be surprised to see this appearance on CT or MR, but if you look at the CT feature, it is almost isodense with the spleen. It's almost isointense with the spleen. Concerning gallium PET, we have to remember that there are somatostatin receptor at the level of the lymphocytes of the spleen. So accessory spleens can show this type of appearance. So more recently, we had another case, probably similar to this one. This patient was observed in another hospital for an abdominal trauma, and for that reason, he performed a CT scan. And these are selected images at CT, computed tomography, which showed an area of increased density in the tail of the pancreas, which showed enhancement following contrast administration. So again, also in this case, the hypothesis of a vascular tumor was formulated, and for this reason, the patient was moved to perform a gallium PET, and similarly to the previous case, the lesion, the tail of the pancreas, showed high intensity at gallium PET with the SUV maximum of 9, which is relatively high. And so also for this patient, the hypothesis of neuroendocrine tumor was proposed, or whether this patient was examined by us with magnetic resonance imaging, probably on the basis of that previous case, which we had experience of that previous case. So at MR imaging, we see probably in this T1-weighted FATSAT image a low signal intensity area in the tail of the pancreas, which is highly vascular following contrast administration, with decrease in the portal phase. We added to the protocol diffusion-weighted imaging, and we can see that there is high signal intensity. However, at MR imaging, we could demonstrate that this patient had an additional round small mass located at the hilus of the spleen, which was vascular in the arterial phase, isointense with the spleen in the portal venous phase, and high signal intensity due to water restriction molecules in diffusion-weighted images. And there was an additional small mass which was located below the spleen and which had similar imaging characteristics: vascularity during the arterial phase, washout in the venous phase. You have to believe me because we do not see very well the diffusion-weighted image, which shows high intense. So all the three areas we saw in this patient had similar imaging characteristics on non-contrast, contrast-enhanced, in the arterial venous phase, and also in the diffusion-weighted images. So this lesion, these small masses were detectable, of course, also at PET-CT, and with the similar imaging characteristics of high signal during the PET-CT scan. We move on. And also this very small one had sub-values of about 9, like the principal lesion at the tail of the pancreas. So in this case, we made the hypothesis, a different hypothesis, also because of the experience of previous cases like this of polysplenia. So this patient probably has multiple small accessory spleens which may simulate the presence of a neuroendocrine tumor, and for this reason he was not operated and is on follow-up, but we are rather convinced that this case represents the presence of multiple accessory spleens. Accessory spleens, so therefore, may present a diagnostic challenge for neuroendocrine tumor because they have a very similar appearance to that of the tumor, of course, especially when they are located in proximity of the tail of the pancreas. Just to emphasize these differential diagnostic problems, I want to mention this paper that was published recently, in which the value of diffusion-weighted MR images is considered to make this differential diagnosis. Diffusion-weighted images in these particular studies proved to be more effective than the other imaging sequences, especially if we compare the values of the signal intensity or the ADC values with that of the spleen, and you will see that the values are very, very similar to that of the spleen. So this paper supports the value of diffusion-weighted imaging to make the differentiation of intrapancreatic accessory spleen for small, solid pancreatic tumors, like in the case I've showed you. But I want to come back to the CT images. I think that the diagnosis was already there, because this was the accessory spleen close to the hilus of the spleen, and this was the small accessory spleen at the level of the inferior pole of the spleen. So sometimes it's enough to look carefully at the images without performing so many studies to reach the final diagnosis. Anyway, it was an interesting example of the problematics of the differential diagnosis for this type of lesion. And just before to finish with the cases, I want to show you a particular presentations of neuroendocrine tumors in the pancreas. Well, sometimes you will face with cases in which you see a dilatation of the main pancreatic duct without any visible pancreatic mass causing this type of stenosis. This is the images in the arterial phase, the T2 weighted images, the venous phase. Probably only in the venous phase we can detect a mild increase of the signal intensity due to contrast accumulation, but this is not convincing at all. Well, we had experience with a number of cases with this type of presentation, and we have learned that this may be one of the presentation of neuroendocrine tumor. Which type of neuroendocrine tumor? Of course, this was operated. This case was operated. This is the small tumor, and this is the histology of this tumor. This was a serotoninoma. Serotoninoma is one of the possible tumors one of the possible neuroendocrine tumor. It could be functioning, but as you know, this type of tumor do not produce enough hormones to cause symptoms. But they can produce hormones to induce fibrosis. And in fact, this was this case. This very small tumor produced fibrosis like the carcinoids we see in the bowel. And for this reason, they produce fibrosis and stenosis of the main pancreatic duct. And I can address you to this interesting paper that reports a number of cases like this, pancreatic duct stenosis secondary to small neuroendocrine neoplasm, a manifestation of serotonin production, a particular manifestation of this heterogeneous family of tumors. So at this point, we finish up with our presentation. Of course, the discussion is open for the radiological and the surgical and the oncological presentation. Thank you very much. If there are questions from the audience, we will be delighted to give you answers. One key that, yes, probably did. Sorry, I didn't see you because of the lights.
I want to raise a question.
Can you come to the microphone, please?
In your case, you just presented, there was a CT perfusion scan for the patient to see whether the tumor has some perfusion change during the therapy. So what do you think is the role of CT perfusion in those pancreatic endocrine tumors? Thank you.
Thank you for this question. This is a part of a study we are performing actually. So this, we have not definite results from this study, but we are following a number of patients with perfusion CT at T0 and during therapy. It seems that perfusion CT is able to show early changes following therapy, following everolimus therapy in particular, because we are applying this technique in patients treated with everolimus therapy. So we can see with perfusion early changes concerning perfusion and especially blood volume. It seems that blood volume is the first parameter which change following this type of therapy. We have almost ready to present our data on this type of application of perfusion CT.
So, thank you. So what about those DWI, MRI, and other imaging modalities in the patient monitoring? So what's the advantage of each modality, and how do you choose? Because we all know that CT perfusion has a lot of radiation.
Yes. Well, this is a correct question. I agree with you. Of course, we are trying this technique in a number of cases. We will see the results, and after that we will decide if it is proposable for clinical purposes. MRI is also interesting. Perfusion could be performed eventually with MRI. MRI is interesting for the diffusion-weighted images. There is an increasing interest and application of diffusion-weighted images in this type of tumor in particular. For instance, there is a recent study which has shown that DWI is different in G1, G2, and G3, at least in G1 and G3. That can be an additional parameter to separate these types of tumor. And so I think MRI can have a very interesting role in the diagnosis and follow-up of this type of neoplasm. I totally agree in the possible roles of MRI.
Thank you.
I have a question for Professor Tortora. In your presentation, you showed that with the everolimus, we do not have a change of the size of the tumor, probably. We probably will see a change of the vascularity of. This is important also for us because it is important probably to know which type of therapy the patient is performing and what we should expect for this lesion. So if we see stability, tumor stability, that can be considered already a good result. I want to be convinced that...
Yes, this is a very important issue because actually we are experiencing this with the great majority of target therapy, not only neuroendocrine tumors, but in general, because this type of treatments can increase sometimes very remarkably the survival. So if you look at the progression-free survival, it's a very long term and a gain in survival. If you look at the response rate, many times the response rate is low. So we have changed completely our way to look at and to evaluate the response. Because with chemotherapy, response rate is very important. With targeted therapy, response rate is not that important. Progression-free survival is increased. So we ask you to do the same for this type of lesions, to look inside rather than only look at the dimension, the bidimensional measurements. Because many times, sometimes you see a shrinkage. In some cases, renal cell cancer, for instance, you see big shrinkage. But in other cases, you don't see a shrinkage, but then you see a change in the architecture with a lot of necrosis inside, and that corresponds to an increase in survival, usually.
Prego.
Thank you. I have a question for Professor Tortora. I think it is very important to stress one situation, and the question is if this situation is possible. During follow-up of, in example, 5 metastatic lesions from endocrine tumor in the liver, we did some therapy and we expect a reduction of vascularization. It's possible to have the response only in one lesion and not in the other one?
Yes. An heterogeneous response, yes, it is possible. It's what we call mixed response. Finally, you have to make an average and you have to consider if it's possibly a stable disease when it's like that, unless you have a lesion increasing a lot. This is something that we see very often. And
I think from a radiological point of view is very important because there are some methods, imaging methods that focus only on one lesion, and then we need more panoramic view. So in this example, for me, CT perfusion is better than contrast ultrasound focused on only one lesion.
There is an explanation for that, a biological explanation. Tumors are very heterogeneous, and some molecular lesions are overcome by mechanism of resistance. So it may happen that in one tumor or in one metastasis, you have a prevalent signaling pathway, and your inhibitor can hit that pathway. In another lesion, you have a mechanism of resistance taking over, and another pathway that is leading the growth of the tumor. And the drug that we are using is effective against that pathway. And so you see these heterogeneous responses.
Thank you.
Professor Marordi?
Yes, I have a question for you about this final aspect. I think it is very important to see that there is an heterogeneity in these lesions, and it is also possible with technical imaging to analyze the heterogeneity. So my question is, have you experience of texture analysis of the lesions? Because it is possible to separate the organization of the tissue due to the neoangiogenesis, and therefore there are areas that can be characterized by a very great amount of vessels, and that could be also areas that are characterized by a complete different behavior.
Well, I have no experience on texture analysis. The attempt of perfusion CT was to approach this type of problematics you mentioned. I think it's a matter of study of research, what you propose.
Yes, I mentioned this because we did this with the metastasis for the colorectal carcinoma, and the response to treatment is forecast by the texture analysis, and the treatment is bevacizumab. So I think this can be a good point to analyze.
Thank you. Thank you for your observation. So I think the time is over. So I thank you, Professor Bassi and Professor Tortora, for being here, and I thank you all for the participation to this session. Thank you very much. Goodbye.